Well, good morning. I'm a family physician by training. I went to medical school here from 1970 to 74.
There you go.
Thank you very much. Then I did a family medicine residency from 74 to 77, and then I moved to a small town about 60 miles outside of Houston, a little town called Wharton. And I was a country physician in Wharton for 21 years, from 77 until 98. In 98, I moved back to San Antonio to become the medical director of our CareLink program, and I now oversee the ambulatory operations of the health system. Interestingly, one of your faculty, Robert Swatek, when we lived in Wharton, we lived out in the country, and we didn't have many neighbors because everybody lived apart. But Robert and his brothers and sisters lived just around the corner from us, and Robert's the same age as one of my boys. And so I was really... Somebody was saying that a couple of years ago, hey, we got this new Dr. Svatek or something. And I looked at that and said, no, that's not Svatek, that's Swatek. So Robert, we've known him and his family for a long time. I am going to talk this morning about CareLink and the uninsured. And I think when we talk about CareLink, and CareLink is a local program, it's a Bexar County-only program. We've had to develop, and not just us, but other areas have had to develop programs to take care of the uninsured because there really is not a state program that takes care of the uninsured. Medicaid is not that. Medicaid is great for women. It's great for children. It's great for people who have disabilities and who don't have any source of income. But if I lost my job tomorrow and my income went to zero, I don't qualify for Medicaid. So really counties and cities have had to step forth to come up with programs. So just to start off, you're going to see data from different years because not all the data gets refreshed at the same time. This is the most current stuff we have. Can anybody tell me what we as a nation in 2010 spent for health care? This is seeing the doctor, this is going to the hospital, this is paying for prescription medicine, it's getting an oxygen tank. Anybody got an idea as to what we as a nation spent? Rough figure. How much? Well, we actually spent $2.6 trillion. That's a lot of dollars. That's $8,400 for every one of us. So just look around, and each one of us, that's $8,000. Look around at all the people we passed driving in this morning, all of our kids. That's how much got spent in 1 year for each one of us. It's almost 18% of our GDP, and the GDP is the gross domestic product. That's the sum of all the goods and services that we as a society put together. Awful lot of the dollars that we have laying around, we use those over for healthcare. It makes it hard for General Motors to sell a car that's competitive around the world because that cost has to be added in, and I'll show you a couple of slides on that. So it is about 18% of the gross domestic product. When I started medical school in 1970, we didn't talk much about money. And in fact, these talks could really be titled Money in Medicine, because that's really what this is about. Medicine healthcare costs a lot of dollars, and so how do we do this? So when I started medical school in 1970, as a nation, our expenses were $74.9 billion. Now, to be honest, you have to adjust those numbers moving forward, and you probably have to multiply them by about 4. So if you took $75 billion in 1970, you'd multiply that by 4, and that would get you to $300 billion. So take the numbers down the left-hand column and multiply it by 4 to get to today's numbers. The way that this is reported out, and a lot of this comes from the journal Health Affairs, very well-read, well-written journal. But if you do that, we spent $75 billion. When you come down to that bottom, that national health expenditures per capita, we only spent $356 per individual for our health care. So it wasn't a big deal. We didn't have a lot of the fancy, expensive stuff we have today. There were certainly no robots doing surgery. We didn't have MRIs. We didn't have a lot of the cutting-edge medications that we have today. Tetracycline was pretty good, and tetracycline pretty cheap. Amoxicillin was pretty good. Amoxicillin was pretty cheap. So we didn't really have a lot of those costs. But if you move forward to 2010, you can see that our costs have really increased. One of the problems that we have, and I'm going to use 1999 as the starting point, 38%. So if I'm going to buy something in 2012 that I would have bought in 1999, if it cost $1 over here, I need $1.38 to be able to afford it. Now, fortunately, wages over that same period of time have gone up 42%. And that's what you want. You want your wages to keep track with inflation so that you can continue to buy what you could in the past. If they don't keep track, then you've got problems. And sometimes you'll read about countries having rampant inflation. All of a sudden, the dollars they've got are no good because they can't go afford something. So fortunately, our inflation and our earnings have kept pace. What hasn't stayed on the same level is the cost of health care. And there are two lines here. The bottom line says it's 172% more than it was back here. And that's how much health care premiums have gone up since 1999. And the 180% is what the worker has to pay for that insurance. In the United States, most people get their insurance through where they work. There are a few people who go out and purchase it on the open market, but most of us have it through where we work. If you work for the medical school, you get it through UT. If you work through the hospital system, you get it through the hospital. If you work for USAA, you get it through USAA. So that's the way that most people get their health insurance. The problem is this delta continues to get bigger and bigger. It's harder for employers to provide health insurance. It's harder for employees to afford it, and it's harder for people who aren't employed and getting it to go out on the open market and get it. And each year this delta just gets wider and wider. This shows what the cost of health insurance is going back to 1999 for two groups. The orange is for a single individual. So it's just me. I'm 20 years old. I'm 60 years old. I've got nothing wrong with me. I've got everything wrong with me. But you lump all that together, and I'm getting my insurance through a company. In 1999, the total cost for that coverage would have been $2,100, or actually $2,200. You move forward to 2012, and it's now $5,615. So that's what's happened to coverage for a single individual. Now I get married, it's just me and my wife, or I get married and we have 7 kids. It's family coverage. It goes from $5,800 in 1999 to almost $16,000 this year. So that means that every time, if you own a business and you're going to provide health care coverage for your people, every time you hire somebody, if they've got a family, you're taking on $16,000 worth of cost. That's why it's hard for great big companies to make sense of their budgets moving forward, is because this number continues to go up, and that's a very big number. A lot of what we're going to talk about today revolves around what's called the Federal Poverty Guideline. In the United States, and this is only good for the 48 continents, it's a little bit different number for Hawaii and Alaska. But when somebody says that you are at 100% of the federal poverty level, and you're going to hear about this today as they talk about health reform, because a lot of health reform deals with where somebody falls in regards to the federal poverty level. So if I am a single individual and I make $11,170, then I'm considered to be at 100% of the federal poverty guideline. I'm married, so there's 2 of us. Our combined income is $15,130. That's considered to be 100% of the federal poverty guideline. It goes up, and for each additional person over, after you reach 4, you add another essentially $4,000. So this tells anybody who's looking at you where you fall in regards to the federal poverty guideline. And we'll talk about this later on as we talk about Medicare and Medicaid and some of the other assistance programs. But I do want you to remember that for a single individual, 100% is $11,000. So what's caroling? Well, in the state of Texas, really the state doesn't do anything to help uninsured individuals. That's left up to the county. And so you see counties like Travis County and Bexar County and Harris County and Dallas County and Tarrant County and Lubbock County and the counties that have large teaching institutions, they tend to be the counties that take care of the uninsured throughout the state. That's why a lot of people come here that live in other counties. Counties are only obligated to help you with your health insurance in the state of Texas if your income is below 21% of the federal poverty level. So we just said that's $11,000, 21%, that's probably about $2,300, $2,400 per year. So if you're making $200 a month, that county has no obligation to help you. I don't see many people who are making it on $200 a month. So almost always the people in those counties who need help, they've got to go somewhere else. And the other thing is they only have to use 8% of their tax revenue, and once they've used 8% of their tax revenue, then they don't have any money left over and there's no obligation, so they don't have to help you moving forward. Their tax year starts September the 1st, so if you do qualify, you better get your care in September or early October, because it's going to be gone after that. So we really don't have a system that takes care of it. So in Bexar County, what we've done, we have a hospital district. And I would tell you we're very fortunate, in my opinion, to have a hospital district in Bexar County. It was voted in 1955. What you need to remember is that in 1955, you couldn't just walk up and vote. You had to own property. You had to be able to pay taxes and showed somebody that you paid taxes, and that was called the poll tax. And if you didn't own property and you didn't pay taxes, you didn't get to vote. So it was the people who owned property, who paid taxes, who voted in the hospital district. And that's what we use today to help fund our CareLink program. So our CareLink program helps residents of Bexar County pay for the health care that they need. We established the program in 1997. We currently have it's actually 54,000 members. You have to be a Bexar County resident. So if you live in Bernie, doesn't count. Live in Jourdanton, no help. You also have to be below 200% of the federal poverty level. So we said the other counties it's at 21%, and Bexar County it's 200%. So if I'm a single individual, if I make up to 200%, which would be about $22,000 a year, I can still get in this program. And remember, if I had to go out and purchase that insurance by myself, that would cost about $5,000 from that earlier slide. If I'm only making $22,000 a year, I don't think I'm going to go out and spend $5,000 of it on health insurance. It's just not going to happen. We just don't see that. So you have to be a Bexar County resident. You have to be below 200% of the federal poverty level. You also cannot have moved here for medical services. Several years ago, I had 2 phone calls over the course of a month. Somebody wanted to move here for a transplant. And I said, that's great. I'm happy you're going to do that, but CareLink is not going to fund it. You're going to have to find another way to get that funded. We have people who live in other counties who need dialysis, and they want to move here for their dialysis. They can move here for their dialysis, but CareLink isn't going to pay for it. So you have to be a Bexar County resident, you have to be below 200% of poverty, and you didn't move here for medical services. But that's it. There's no other qualifiers. CareLink is not an insurance plan. Insurance plans work. They get all of us together in the same plan, and there's a premium. And so every single month, each one of you and me, we all pay a certain amount into that plan. Next month, when I get sick, all those dollars that we put in get used to pay for my care. And so I need lots and lots of people in that program to help pay for my cost. That's not what CareLink does. CareLink doesn't charge a premium. So if I enroll in CareLink, but I don't get sick, I don't go to the hospital, I don't need anything, I don't pay anything. Once I do get sick, then CareLink steps forward to help pay for that cost. It's a partnership. The patient has to pay something, and I have to pay something. We do have a defined provider network. We ask our members to have a PCP. We don't want them to go to the emergency room over and over again. That's the most expensive place to get care. We want them to have a primary care doctor. We have about 18 clinics scattered all over the county where we provide care. Doesn't always work perfect, but that's what we're trying to do. There's a monthly obligation. And I'll show you a chart here in a minute, but there is a certain amount that they have to pay, and that's related to how many people are in the family and where they fall in regards to the federal poverty guideline. And there are co-payments. If they go to one of our express meds, they have to pay something up front. If they go see their family doctor, they don't have to pay anything. If they go to the pharmacy, they have to pay a co-pay, although we've tried to structure it so that nobody goes without their medications. It doesn't make any sense at all to incur a $10,000 hospital bill because somebody couldn't go afford a medicine that cost $25. So we never, ever want to find ourselves in that shape. We do have a plan that takes people up to 300% of poverty. Every time you set some sort of guideline or cutoff, there's always somebody who falls just above or just below that. And we have individuals who come to us who are at 210 or 220% or 300% of poverty. We know they have an ongoing need for health care. It's going to be cheaper for us as a county to bring them into a program where we can help manage that. So we bring them in. They have different rules. They don't quite get all the benefits, and they have to pay an awful lot more for the care. But we do actually take a few people up to 300% of poverty. That's our membership over the last 4 or 5 years, pretty stable. It went up as the economy got worse and people lost their jobs. It's begun, at least in Bexar County, it's begun to come down some. We take our CareLink members and we place them in different categories because somebody who's at 10% of the federal poverty level is a lot different than somebody who's at 280% of the poverty level, and we recognize that. So this blue bar that you see on each one of these, and these are 4 years of data, the blue bar is our CareLink A. Those are the individuals who are at 75% of poverty or below. We consider those truly indigent. We would never deny them services. If they don't have the money for the copay, they're still going to get their medicines. We're not going to kick them out of the CareLink program if they don't make their payments. If their kids come in, they're going to get whatever they need. So if you're below 75% of poverty, we still ask the same as we do for everybody else, but they're not absolutely required to do that. Our biggest group is the red bar, and those are the individuals who are from 76 to 150% of poverty. They have a copay, they're expected to pay for it. They have a payment plan, they're expected to pay for it. If for some reason they have difficulty making their payments, we'll meet with them. You know, maybe daddy's hours got cut back, or maybe his hourly wage got cut back, and we need to reclassify him. But we'll work with these individuals, but if they don't make their payments, then they'll come off of CareLink. And many times you'll see individuals who used to be on CareLink. And I can almost guarantee you the reason they're not on CareLink is because they didn't keep up their payments. We'll bring them back in, we'll work with them, we'll set up some sort of a payment plan. We don't want them outside CareLink, we want them inside CareLink. But they have to make their payments. That's the way we keep the program going. And then you can see the green bars, our CareLink C, those are the individuals from 151 to 200%. We have our Plus plan, which is 200 to 300. And then we have a small group that's MedLink. These are individuals who are very poor. We help them with many of their copays. We help them with the 20% copay that they have to pay for their Medicare. And so it's a small program, but it helps people who otherwise wouldn't have any help. This is where our members live. So they all live within Bexar County. And a lot of people say, well, it's a program just for the people on the south side or the west side. I don't think so. We have a lot of people moving up Interstate 10, out northwest and out northeast. Most of our individuals in this county, they have CMA, which is a provider group that we put together as their primary care physicians. Through the Department of Family Medicine and Internal Medicine within UT, 13.6% of our patients, that's their PCPs. We also utilize the federally qualified health clinics out in the community, CentroMed and Communicare, and we use a private practice group, South Alamo. Our patients are reflective of the population, hypertension, high cholesterol, diabetes. I'm not quite sure why we have so much thyroid problem, but we have an awful lot of individuals who are hypothyroid, and we have a lot of people who are depressed. This is in our county. This is who we're providing services for. And what it shows is that in 2011, we had 270,000 primary care visits, but we had 309,000 specialty visits. So that's coming to see the urologist, going to see the cardiologist, seeing the dermatologist. In 2012, our numbers have moved up some. Now, we only have 24,000 admissions at our hospital every year, but you can see we have 68,000 emergency room visits, and you can downtown we have 155,000 visits. And there's just an awful lot of activity takes place. About half of the individuals who are in this system have CareLink. And so in the old days, we would have continually struggled with what they needed, how they got it, how it got paid for. The CareLink program has helped us tremendously. But again, it's just for Bexar County, so it doesn't help you if you're not living here. Now, we talked earlier about the cost of health insurance. If you go out on the private market and you get it, it's a breakdown between you and your employer. So I showed earlier that the cost of care, if you got it through a company and there was a family, was somewhere in the 15.5 range. This is a blend of small and large firms. You as a worker, your cost is almost $4,000. So, and this is certainly true for me at University Health System, the hospital picks up $12,000 and I pick up $4,000. So every year when there's an increase in premiums, my premium goes up just like the hospital's does. I could have received this as wages if we had a different system. Might not have. The system might have used it for something else. But that's how it's broken down. Now, if I'm an individual, I'm going to probably pay about $1,000 a year. So some of you who are single, and you look and you see how much you're paying for health insurance, and you get married and you see how your premium changes, that's exactly what's happening. You're going from about $1,000 to about $4,000 a year. With our CareLink program, we've talked a lot about who's in it, how it's structured. Let me talk to you a little bit about what the cost of the program is. A managed care company, when they look at cost, they'll say, okay, here's Dr. McWilliams. He joined the program in January. So it's the end of the year. So he joined it in January. So we've had him for 12 months. Here's Dr. Bosler. He joined it in November. We've had him for 2 months. So there's 14 months of activity. And then they'll take the total cost and they'll divide that up and they'll come out with a per member per month cost. So there was 2 of us, it was 14 months, the cost, so they make that. And so what you're seeing here is what's called a per member per month cost. So for our CareLink members, the cost, and this is being in the hospital, seeing the doctor, getting their medications, all the things that we cover, their cost is about $164 per month in 2008. And we've been able to keep that pretty flat. In 2011, it was still $164. We collect from our members. They have an obligation. They also have a pharmacy copay. What we collected in 2011 was about $31 per member per month. So what we didn't get from the individual, this is what the county has to step forth and pay. It's $133 per member per month. Now, if I multiply that by 12, I'm going to get about $1,500, a lot less than the $5,000 that we were showing earlier that health insurance for a single individual cost. So we think we're delivering a pretty good product at a cost that isn't very much to the county. Here's what an individual within CareLink has to pay. So when one of your CareLink members comes in, if they're married and they have an income of $20,420, let's say Daddy was in a car wreck. The hospital bill was $25,000. What that family has to do is to make a payment of $86.12 for 48 months. And when they make that payment for 48 months, then their obligation is gone. Let's say that they make their payment for 10 months, and the next month, Mama is in a car wreck, and her bill is $25,000. This doesn't change. That's $86.12. Now, you've got to extend that out 48 months, but it doesn't go up. And what we found is that with this structure, and it's a lot more involved with this, but with this structure, most of our members are able to afford their payments. And so we've set something that we believe is reasonable. It is a partnership. We sell it to the members. We remind them, you've got to pay your part. This isn't free. You've got to pay your part. That's how we're going to keep this afloat. Many of our CareLink members, when you see them, when we see them, they truly have CareLink. But we're able to retro-qualify them for Medicaid. And that's what most of this shows, is that in 2011, there was $7.2 million worth of services delivered to our CareLink members. We thought, and they were indeed on CareLink when they came in, but they retro-qualified for Medicaid, and those are recoupments that we were able to receive from Medicaid. So a lot of our members do move on to Medicaid. We're very thankful that Medicaid exists, But a lot of our members moved to Medicaid, and we're able to recoup that. Now, a lot of them come back from Medicaid. They get pregnant, they have their baby, and then their period is over, and they come back, and they're back on CareLink again. We utilize a formulary system. There's a P&T committee at the hospital. Dr. Shepard chairs that. They meet every month. They determine what medications we as a health system are going to provide. If you have a new medicine that you want added, you go before his committee, you make your presentation, they say yes or no. One of the things that we're able to benefit from, because we take care of so many individuals who don't have much money, we qualify for what's called 340B pricing. It is a great program that was set up by the Fed some years ago. It gives us medicine to dispense and to provide to our patients at a cost. The only people who get medicine cheaper is the Department of Defense. We get medicine cheaper than Walmart, than H-E-B, Target, all those places, because of the population that we serve. And it's probably at least 50% less than the average wholesale price. That's another reason that we're able to keep our drug costs down, is because we can obtain these medicines so inexpensively. We also utilize the medication assistance programs. When I went into practice, I didn't know much about this. These are programs that the pharmaceutical companies set up themselves. There's nobody that told them that they have to do it. Yes, they get a tax benefit every time they donate something, but these programs are set up by them. They call the shots, they make the rules, we just simply play by them. I would have individuals who would come into my office who needed a medication, and one of their friends had told them, you know what, I think you can get that medicine for free. So they'd come in and would talk about their situation. There'd be some forms to fill out. We'd fill it out. We'd send it in. And sure enough, the pharmaceutical company would send them that medicine for free. Now, sometimes it didn't happen, but most of the time it did. When I came here, we were doing it on a very small basis for some people within the hospital. And I thought, gosh, I think we can do this for our outpatients, and we can do it a little bit better. And so we were able to grow the program. And in the first year that we actually tracked our savings was 1999. A minute ago I told you we got drugs at 340B cost. Well, what we do, if we get 100, and this is a true example, we were able at one time to get a bottle of 100 Prozac for a penny. So if we got a bottle of 100 Prozac in, we counted it as 1 penny. If there was another medication, whatever our acquisition cost would have been, we put it up here. So the first year that we tracked our savings, we saved the taxpayers of Bexar County $157,000. We're patting ourselves on the back. Man, that's a great program. Look at how much we saved. But as we ramped it up and we built the department up, gosh, we got all the way up to $17 million in 2005. Now, the reason it came down in 2006 is because that's when Medicare Part D started, and we'll talk about that later on this afternoon. But over the history of us tracking this, and this doesn't include this year, we've got $154 million worth of savings to the taxpayers of Bexar County. We have a new clinical building that's going up downtown. We're just about ready to move into it. The 6-story building with everything that's inside it, MRIs, CTs, all the fancy stuff, cost us $135 million. So that building costs less than what we've been able to save right here. So we think that that's been a great program too. I know it's a hassle. Sometimes your patients come to you and they need something, and we have to get the medication through the medication assistance program. But we have about 18 individuals who that's their full-time job, is to make this happen. We send our patients to Walmart, Target, H-E-B. If there's a medicine that they can get cheaper for $4 or $5, go for it. These programs are not linked to income. Warren Buffett, Bill Gates, any one of you can walk in and get Dr. Bosler, you can walk in and you can get 30 days worth of medicine for $4 or $5 depending on where you go. So there's absolutely no requirement. Now, why do they do this? One, it's good PR. Two, you're probably going to buy something else when you walk in there. This isn't going to be the only thing you're going to obtain. Three, most of these are generic medications. They don't cost very much. They are able to buy them at large discounts. But these are great programs. And for any of you, for any of your family or your friends or your patients, if they're struggling with something, always, and they don't have to be on CareLink, obviously, because this program doesn't work with CareLink, but these are great programs, and they're everywhere. So in 2000, this says 2012, this is actually our Medicare Part D program. Medicare Part D actually started in 2006. Before 2006, there was very limited assistance for individuals with outpatient drug needs from the Medicare population. The only people who got help were those people who had end-stage renal disease, and they could go get some of their medicines paid for. But anybody else, pretty much out of your own pocket. And it was whatever the plan was that came about. In 2006, we started the Medicare Part D program, which was specifically designed to help with outpatient drug costs for people with Medicare. We do this, we utilize this for a very small portion of our CareLink population who also qualifies for some assistance through Medicare. And I'll go into it in more detail later on this morning, but it's another program where we can help control our drug costs for our outpatients. Because of all the things that we do, we've been able to trend our per member per month pharmaceutical costs down from 2004 from about $9.50 to $7 in 2010. I would tell you we're going to be about $7.50 this year. Our costs have gone up just a little bit, but I don't think many other places have been able to keep their drug costs down. But that's because the P&T committee with the UT physicians who sit on the committee doing a really good job. That's because of the medication assistance program. That's because of using Part D. And it's also because we encourage our patients to go get the $4 or $5 copay medications when they can. Another thing that we do, and you're going to hear this later on, there aren't enough physicians to take care of the population. And we've got to make sure that we're using our resources correctly. So when we have a podiatrist, we can't send patients to them to get their nails trimmed. We've got to send patients to them who really need to see a podiatrist. When we've got a urologist, we can't see patients to them who have a urinary tract infection. We have to have some sort of guidelines that ensure that the right person is getting to the right level of care. And so about 12 years ago, we invested in a national program called InterQual. It's available on our homepage, intranet. There's no login that's required. You can go in, you can put all this stuff up. What we do ask is that when the primary care providers decide that they want to refer or they need to refer a patient to a specialist or for a specialty procedure, that they use the InterQual criteria. And this is, I should have made it urological, I apologize, but this is GI. So if I'm a family physician or an internist and I want to send somebody because I think they've got bad reflux, well, I can only send them if they've got reflux after they've been treated. Well, what does that mean? That means that they have to have symptoms, upper abdominal pain or chest pain. They have to have heartburn, so they have to have one of those. And they have to have continued therapy after they've had lifestyle modification and they've been on a proton pump inhibitor for greater than 4 weeks. And if they don't meet those criteria, then we don't move them through to the gastroenterologist. And so these are the guidelines that we use throughout the system. Every year we get a new set of guidelines, and I invite the division chiefs and the department chairs to come in and look at these because we can modify them ourselves. But this is how we're trying to control the fact that you're going to get patients that you think have been appropriately screened and worked up. If you have issues with some of these, just bring it to our attention. We're always happy to sit down. It's a two-way street. We work with the primary care providers as well to make sure that they understand how to use these. But we're not just going to send everybody up the system. We, this year, will handle about 120,000 requests for referral to a specialist or for a specialty procedure. Several years ago, the Robert Wood Johnson Foundation did a study looking at safety net programs, and that's really what we are. We're a safety net program. They looked at them around the nation. They said, so who's doing what? What can we learn from different programs, and who's doing a decent job? And there was a gentleman from Wake Forest, Mark Hall, who came down, and he looked at programs in Colorado, Michigan, North Carolina, and Texas. We happened to be the program that he looked at in Texas. And we were very fortunate. What he said was, he said, these guys are taking care of the uninsured at about half the cost of Medicaid and half the cost of private insurance. And he took our claims experience, they took a lot of information and sat down and ran through this. And so because of this, Our CEO and others have been asked to come to different places and say, tell us what you're doing in Bexar County, how you're taking care of the uninsured, how you're able to get pretty good care at about half the cost of either Medicaid or private insurance. Now, to be honest, we're not like Medicaid because we don't have pregnant ladies. We don't have a lot of children. That's a different population. But when you take what we're doing, this is what the outside review came up with. So as a program, we have to provide a certain level of care, but we're not going to provide everything. That's called a schedule of benefits. What are you going to make available to the individuals? So they have to be seen within the university health system. We don't pay for somebody if they walk over to Baptist and say, I want to be seen. That's certainly their prerogative. But as a system, we're not going to step up and pay for that. So they have to be seen within our system. They have to either see one of our family physicians, community medicine, they have to see a specialist within UT, or if we have a contract with somebody else. But if they don't fall in this group, then we're not going to help pay for the cost. So that drives an awful lot of the care back to us, but that's how they get that covered. We do not typically pay for services that are away from the system. There are a couple of things. Actually, radiation therapy now happens within CTRC, which is part of the UT system. Open-sided MRIs, we don't have one. There are large individuals who won't fit in our MRI. There are people who have claustrophobia. They're not going to tolerate our MRI, so we have to pay to send those out. PET scans, we don't actively use a PET scanner within the system. We use Aurora Imaging, which is down Floyd Curl Drive. And then we do our bone marrow transplants at Methodist because our system had a bone marrow transplant program and we lost that a number of years ago. We know that bone marrow transplants can be life-saving for many individuals, so we've worked with the providers at Methodist. We've worked with Methodist itself. They let us pay them at the Medicaid rate so that these individuals can get their bone marrow transplants. We do have, like I said, contracts with others that allow us to send some patients there, but we always require pre-authorization if we send somebody outside the system. So if somebody shows up to get a bone marrow transplant done at Methodist, if we didn't pre-authorize it, whether they were a CareLink member or not, we're not going to pay for that. And that's the way most insurance companies would do too. They'll be happy to pay for things that you need, but they need to know about them ahead of time and make sure that they meet criteria. If somebody shows up in another emergency room, we typically don't pay for that. What will happen is if that emergency room knows that they've got CareLink, as soon as they can, they'll steer them our direction, and so they'll come to us. But we don't pay for them going to the other emergency rooms. We ask them, again, to utilize our system. If something costs more than $250, then we're going to pre-authorize that. So if there's something that you're doing in your office and the Medicare fee schedule, and we pay off the Medicare fee schedule, and I'll go over that after a while. But if the cost is more than $250, we're going to ask that be pre-authorized. If the cost is less than $250, we're not going to do that. You can do that in your office, and nobody's going to say no on that. We do help. There's a number of homeless. We have the Haven for Hope downtown, which has been a magnet for the homeless. I mean, New York City, we think, probably puts them on buses and sends them down here during the winter. And we'll hear the people from Haven for Hope say, okay, it's getting cold. We need to get ready for the influx of individuals from Cleveland and Detroit and New York. So jokingly, somebody said, well, maybe we need to have those buses go both ways in the summertime. But we get a lot of individuals who are homeless, and sometimes they need some help. There is an FQHC Centromed that has a clinic on site at Haven for Hope, but some of those individuals need a little bit more, and so we work with them. And sometimes, I don't know if any of them come to see urology or not, but we'll help them with some of their health care costs. These are things that we don't pay for. We don't pay for acupuncture. We don't pay for cosmetic surgery. That doesn't mean that we don't pay for all cosmetic surgery. If a lady's had breast cancer and she's had one of her breasts removed, we'll pay for the reconstruction. We'll pay for a couple of follow-up procedures. But if somebody just wants the wrinkles taken out or a little tummy tuck, that's fine, but that's on them. We don't pay for anything that has to do with sex change, and I will tell you, we get requests there frequently. But there's an awful lot of things that we don't pay for. I think if you look, though, this isn't that much different from some other plans. And then the things that we do pay for, pretty much any hospital stay, anything that's considered urgent or emergent, we're going to step up and pay for that. We get calls frequently about, is this covered or not covered? And we'll try to give you an answer immediately. If the people who answer the phone can't tell you quickly, they'll usually call me or page me, and we'll talk it over, and we'll make something happen as quickly as possible. We want to make sure that the patients get the care that they need. Not necessarily the care that they want. And sometimes I'll get a request that comes through and it says the patient wants something. I know what that means. I'm a physician. I used to write the same thing. That's me telling somebody on the other end, hey, I'm not asking for this, but the patient wanted it, and so I'm going to let you know that. We'll look and we'll see, but most of the time we don't authorize those. But if you as a physician think that this is really necessary for this individual, for their well-being, we're going to probably make that happen. Here?
On the non-covered benefits, I noticed that, we're going to be talking about hospice later, but hospice and skilled nursing facilities are not in there. Is that because they can usually get paid for by somebody else, or is that
No.
just
No, it's because of the cost, but I will tell you, this is actually just a little bit behind because we just got an agreement to help with hospice for some of our CareLink members and to help with some nursing home placements for some of our CareLink members because they're in the hospital 250 days. They don't need to be in the hospital 250 days. If we'd had some place to place them, they could have gone home 3 months ago or 5 months ago. And so we've been incurring a great big hospital cost when we could have incurred a very small cost for having them in a nursing home or having them on hospice. And so this actually is a little bit outdated. Thank you for bringing that up. And I know you've got a talk later this afternoon on hospice. They may bring that up as well.
Can I just interject one thing?
Yes, ma'am.
How someone going to the skilled nursing facility, they can actually apply for Medicaid and get it a lot easier once they're in there.
Yes. You're going to get some of this in a little bit, but I started putting this in my talks because I think this is the real problem that we as a group of providers and a group of consumers are going to face. I'm just going to show you just a couple of quick slides. This came from the American Association of American Medical Colleges. This is their most current stuff. If you look at the number of physicians in the United States, this is active physicians. So this is me. This is the doctor who's doing research. This is the doctor who sits behind the desk all day. This is the doctor who sees patients all day. If you look at a statewide average, you see there's about 250 active physicians per 100,000 individuals across the nation. Now, on all of these slides, if you look down towards the bottom, you're going to find Texas. So here's Texas. We're at about 200 active physicians per 100,000 individuals. And if you look at the top, you're going to see Massachusetts. Massachusetts is about 400 active physicians per 100,000. Remember, Massachusetts enacted healthcare reform a number of years ago, and I'll show you, because Massachusetts has had problems. Their ER visits went up, they didn't go down. Their primary care physicians got swamped because everybody got coverage, and now all of a sudden everybody's panels were full, and so they couldn't take new patients. So just kind of remember that. Now, there's just 3 or 4 slides. So we've got Massachusetts at about 400 doctors per 100,000. We've got a national average of about 250, and then we've got Texas down here at about 200. So that's active physicians. Now, this is active physicians who actually take care of patients. So this throws out the person who's just teaching, who's just doing research, who's just doing administrative work. So now we still have Massachusetts at the top, but instead of being at 400, they're a little bit over 300. Our national average, instead of being about 250, drops to about 220. And then Texas, instead of being at 200, drops to about 175. So now we're talking about active physicians. Take this down. Let's see. 2 more steps. Now this is active primary care physicians. And this is where we're trying to ask people to go. We're trying to ask them to go see their primary care providers. So now in Massachusetts, we're not quite at the top, we're pretty close. We still have about 110 active primary care per 100,000. In Texas, we're third from the bottom. we're a little bit over 60. So Massachusetts has almost twice the number of primary care physicians per 100,000 that we do, and they've struggled with this. And in 2014, everybody who's at 133% of poverty or less, who's here legally, will qualify for Medicaid. So now in 2013, if I lose my job, and I'm a guy, I'm not pregnant, I'm not a girl, I'm not a kid anymore, I'm going to qualify for Medicaid. So there's going to be an awful lot of people who are going to qualify for Medicaid in 2014 if health reform happens. And I guess what I'm trying to show is that Massachusetts struggled with it, and they've got twice the population of primary care providers that we do. We've got a real problem facing us. Medical schools aren't training enough. There aren't enough residency slots. So we're pushing out the training of nurse practitioners and PAs. We're talking about group visits. We're talking about telemedicine. We're talking about letting RNs do things that nurse practitioners or physicians used to do. People are coming up with all sorts of creative problems. But in 10 or 15 years, this problem's actually not even that much longer. The problem's going to get worse because this is the percentage of active physicians who are 60 or older. That's me. I can tell you what we're going to be doing in 5 years. I'm going to be making sure I got enough shiner. And so if you look in here, that's 25% of all the active physicians are over the age of 60. And I think this problem is going to get a heck of a lot worse. You guys are never going to worry about having a job. You may not like where you're working and you may pick up and go work somewhere else. You're not going to have to worry about having a job. Yes, under healthcare reform, there's a big push to favor primary care. And we'll talk about that later on when we talk about Medicare. But there aren't enough physicians to take care of many of our needs. I heard a talk some time ago from a rheumatologist. This was probably 5 or 6 years ago. And he was showing us the number of rheumatologists that are retiring and the number who are being trained. And it was a huge imbalance. And he said, I don't care if you got a mink stole, if you got a Lexus, if you got all the money in the world in your pocket. He said, there's not going to be enough rheumatologists out there to take care of you. He said, it's not a matter of whether you've got Medicaid or Medicare or private insurance or you don't have anything. He said, they're just going to be full. And I think that we're going to see that with an awful lot of specialties as we move forward. There are a couple of really, really good resources that I always encourage people to look at. Without a doubt, in my opinion, the Kaiser Family Foundation, kff.org, they've got great information, and I think they're unbiased. I read a lot of their information. When I go to meetings, other people quote them. You'll see some charts and some graphs that we have from them later on today. They do a really good job of collecting the information and disseminating it. There are some organizations that, in my opinion, are really biased. And so when I read what they have, I can detect a slant to it. I don't detect that with the Kaiser Family Foundation. I think they put the information out there and then you draw your own conclusions from it. There's an organization for safety net hospitals. This says for pharmaceutical access, but it's actually for safety net hospitals. And it's hospitals like ours and Harris County and Parkland, places like that where we have our information. Then I always close my talk with a couple of pictures. Anybody know what that is? That's right. That's in Zermatt, Switzerland. That's the Matterhorn. And you know who that is? That's right. That's Walt Disney. So this is actually a picture of Walt Disney there in Zermatt looking at the Matterhorn. And he's sitting there, and I just know he's looking at this thing and he's visualizing something. There's a thought going on behind his brain. And what does he do? Well, he comes back and he opens up this theme park out in California. And I'm young enough to remember when it opened up. There were no theme parks. There was no Six Flags. There was no Disney World or anything like that. The very first one, he opens it up out in California, Disneyland. And what's his most popular attraction is the Matterhorn. So he creates this ride and people go there. And if you've ever been there, you see the line for the Matterhorn. It just goes on and on and on and on. So here's somebody who was a dreamer. He made something happen, and he made it a better place for all of us. And I don't know which one of you it is, but there's got to be somebody in this room. Maybe he doesn't create the Matterhorn at Disneyland, but there's somebody in here who pays attention and helps us make this a little bit better for our patients and for really for our whole society as we move forward. My generation, if we could be blamed for something, and we could be blamed for a lot of things, but my generation of physicians got so head down in taking care of patients. You know, left in the morning when it was dark, and you came home at night and it was dark, and we were just taking care of patients. We didn't pay enough attention to policy and to the bigger world around us. And so we let others create the rules and the regulations that we then criticized and complained about. It would have been so much better if we'd been involved from the get-go. We weren't. We let others do that. And so I would encourage you, wherever you go into practice, whatever you're doing, sit on some of those committees. Help make some of the decisions. Think about them and think about how is this going to impact your mama or your daddy or yourself. Not simply from a provider standpoint, but also from a consumer standpoint. I think if we go back to doing that, I think we can make some great decisions. Physicians always want to make the right thing happen. I just think too often we've let others make those decisions for us. So that's really my talk on CareLink and the uninsured. Be happy to take any questions if anybody has any. Yeah.
After about 3 years of birth control pills, vasectomies are cheaper.
Yeah.
It's also a lot cheaper than having an unwanted child and a woman who can't work because she's not pregnant. What's the thought process?
Well, family planning, when CareLink was set up, the structure of benefits was that we weren't supposed to get involved in things that had to do with fertility. Whether it's infertility or fertility, we weren't supposed to be involved with that. We were getting those really through grants, and the grants went away, and so we do subsidize birth control pills. And I will tell you, there are some patients where we're paying for vasectomies. Dr. Lawler downtown is a family physician, does some occasional vasectomies, and we visit with him. If you were to send us some requests for some vasectomies, we would probably sit down and visit with you. That's something that's not hard and fast. We could look at making some adjustments there.
But in the cost of society, if somebody doesn't want more kids,
Yes.
that to me is a no-brainer. I don't understand why that's not routine.
Yeah.
If it mandates us having to get an exception every time,
What we would probably wind up doing would be going back and looking at that as a general policy. I'd be happy to visit with you on that. Yes, ma'am.
You touched a little bit on immigrant healthcare. Being in Texas, obviously we have a lot of immigrants.
Sure.
What is CareLink's role in terms of immigrants?
CareLink doesn't ask if you're a citizen. CareLink asks if you're a resident. Now, do we know what percentage of our members are probably here undocumented? Our best, because we don't ask, I couldn't tell you for sure, but our best estimate is that 15% of our population who's in CareLink probably will not qualify when health reform takes over. And that's when you're really going to know, because come January of 2014, it's going to be pretty obvious if somebody's here legally or not, because anybody who comes in for services, and it's not just us, it's any place else, if they're at below 133% of poverty, they're going to be asking for some proof that they're here legally, that they're a U.S. citizen, and they're going to get on Medicaid. And if they don't have that proof, then you're going to know who's not here legally. But at this point in time, we believe it's probably about 15, maybe 20%. And again, health reform doesn't address anybody who's not here legally. So when health reform kicks in fully, if it does, you're still going to have a large number of people who aren't covered. So it doesn't take care of everyone.
will there be a CareLink program if the healthcare reform goes through?
Yeah, that's a great question. We're planning two options. One, we're planning that it doesn't go through and we continue to operate like we are right now. Actually, we're planning three. The second option is that we're going to have a much scaled down program. Instead of having 55,000 members, we might have 15,000. They would be, as best we could tell, they would be the people who are residents, but they're here undocumented. So they may have been living here for 10 years, but they're undocumented and they're not going to qualify for a program. They're still going to need some sort of health care. Now, I think somebody in the county may have a question about why would I need to continue to fund a program like that, because I thought health reform was supposed to take care of this. And then the third option is that CareLink would just kind of disappear into the woodwork, because there wouldn't be the public support for it, and everybody who's here legally should have some sort of assistance. Remember, if you're at 133% of poverty or below, you're going to qualify for Medicaid. If you're between 133 and 400% of poverty, there's going to be some assistance for you to step forth and purchase some sort of health insurance. So really, under health care reform, there's something for individuals all the way up to 400% of poverty. So if it's me and my wife, 200%, if there's a family of 4, 400% of poverty is like $88,000. That's a pretty high income level. I got a son who's married and they got 2 kids, and I don't think they make $88,000. So they would qualify for some sort of assistance. So those that are at 133 and below will qualify for Medicaid, and then up to 400% will qualify for assistance for health insurance. Yes, sir.
Is there a reliable fast track mechanism to get a patient?
Well, we have offices scattered around the county. For an appointment, it's probably going to be about 14 days. But if you've got somebody and they need to get on CareLink right away, we'll try to make that happen. We have an individual at the hospital who helps us, who when they know, they make rounds and they look to see, who needs to be on CareLink right away. And sometimes we'll cover the individuals. If we can get the process started while they're in the hospital, we'll go back and cover them while they were in the hospital. But if you call 358-3180, which is downtown to our CareLink office, we don't get a lot of those calls, but we do get calls, and we'll do everything we can to enroll somebody today or tomorrow.
So last question, and we have to move on, is, the individual who doesn't qualify for CareLink and doesn't qualify for anything else, and we're seeing them in the emergency rooms. We have a lot of myths that go along with that patient. Like, for instance, if they get admitted, we admit them, then we can do whatever we want to them, and then when they get discharged, they have to figure out a way to pay for their follow-ups. What is the truth in that situation? Let's say you have Joe Schmo comes out from under a bridge with a kidney tumor in the emergency room, bleeding.
If he lives in Bexar County, there's no reason he can't qualify for CareLink. And we have a lot of people in CareLink who don't have any income. So what we do is we sit down and we say, okay, well, tell me what your expenses are. Well, I don't make any money. Yeah, but how much do you pay for rent, or what's your gas bill, or how much do you pay for groceries? And we'll work through that. Now, almost always those are our CareLink A individuals. They're going to stay in CareLink, and they're going to be on CareLink for as long as they continue to be a Bexar County resident. Now, if they didn't come from Bexar County, then that doesn't qualify. But if they're truly a Bexar County resident, then we can enroll them in CareLink.
So if there's no county agreement, county-to-county agreement?
We visited with the other counties, and the other counties are very happy with the way the program works for them, because they don't have much responsibility. They can show people how to get up to San Antonio, or go to Houston, or head it off to Galveston. I used to work in one of those counties. I understand the rules. I know exactly how that game's played. I was pretty good at it.
In Kendall County, I think I saw the budget, there was a whole $10,000 for imaging care for the entire.
Yeah, I've visited with them before, and they're very happy with that. Yeah. Yes, ma'am, you were going to make a comment.
I was just going to say, when Dr. Rascal was saying about the person underneath the bridge, if they have no ID, because they live underneath the bridge, they can't prove that they are from Bexar County, then what?
Well, our program tries to be more inclusive than exclusive. And so, as we tell people, we're not here to be the police. We're going to try if there's somebody who can come forth, and we have a whole list of documents or other ways that we can check off that we believe that they're a Bexar County resident, like Haven for Hope. If they're homeless and they come from Haven for Hope, what we ask the director to do at Haven for Hope is that he gives us a letter that says, to the best of his knowledge, this is truly a Bexar County resident. That's all that we ask.
And that leads to one other question, prisoners. What is the responsibility of the county when it comes to, say, a prison? Say they pick somebody up and bring them to a hospital.
Well, we have a number of years ago, this was not our cost responsibility, it was the cost of the county itself. That's been transferred to us. I'm not quite sure why, but that's been transferred to us. So we actually operate the healthcare down at the jail. We have a big setup down there. We do dialysis, all the other things. And when they come in, then that's our responsibility to pay for that. And so when they come in the hospital, we're picking up the cost for that. One of our CareLink programs is called CHAP. That's Custodial Health Assistance Program, and that's what we do is we enroll those individuals into a subset of CareLink to help them get their whatever it is that they need, whether it's through y'all or through cardiology or whatever. Now, once they leave the jail, then they're off the program, but they can come back and enroll in CareLink if they want to do that. Yeah.
Okay, very good. Thank you so much.
Okay, sure.